Hello everybody, my name is Mandy. I'm one of the dermatology leads for Mind the Bleep. I hope you can all see my screen, but welcome everybody to the Mind the Bleep's UKMLA Final Year Series, the second session in dermatology, where today we'll be talking about A from B and when to worry. If you have any questions, please do feel free to ask them along the way. I'll be keeping an eye out on the chat. And I'll also be checking at the end as well, just in case there's anything that crops up that I can help with. Okay, in that case, we'll just get started. So essentially, in this second session, what we'll be doing is covering some of the presentations and conditions that are outlined in the UKMLA Dermatology content map. There's quite a few, of course, different presentations and conditions, but we'll be focusing on the ones that are commonly will come up in exams in high yield sort of MCQ format, and also trying to figure out how we distinguish between those conditions or presentations and when we would actually worry, which will hopefully be quite helpful when it comes to actually practicing or within clinical practice. I'll get started on the questions, but like I said before, please do ask in the chat and I'll do my best to answer those. Okay, so this is question 1. You have a 35-year-old man who comes to his GP with 2 days of tingling over his lower lip, followed by pain and yellow discharge. He's got no past medical history and he doesn't take any regular medications. On examination, there's a 1 centimeter by 1 centimeter ulcerating lesion located on the lower lip. What is the single most appropriate management? There's a few options there. I'll give you guys a little bit of time to think about it before I move on to the answer. You can also pop them in the chat as well, so I can see that you guys are giving a shot at the answers. Okay, so for this question, the answer here would be E, topical acyclovir. If you're thinking about what this possibly might be, please let me know in the chat below and I'll also have a look. But we'll be moving on to the next question and then I'll wrap up sort of what these different questions actually have in common. So question 2. There's a 9-year-old boy that attends his GP with a 3-day history of coryzal symptoms, general malaise, fever, and a new diffuse vesicular rash on his face and torso after attending his friend's birthday party. His past medical history includes eczema, for which he uses emollients and steroids during flares. On examination, you can see uniform blisters over his face and his torso, some of which appear to have ruptured to form punched-out shallow erosions. What is the most appropriate next step? Is it A, topical acyclovir, B, reassure and discharge with safety netting, C, oral prednisolone, D, oral acyclovir, or E, refer to A&E? Again, I'll give you a little bit of time before I move on to the answer. And just to note that throughout the session today, we'll be using images that are portraying different skin tones. Within the UKMLA exam, they might well present images of different dermatological conditions and presentations in different skin tones and different skin types. And that will be, of course, really helpful when in sort of clinical practice, where of course we'll see quite a diverse population and things can look quite differently on the skin depending on the skin tone. Okay, I'll move on to the answer for this one, which is E, refer to A&E. So before I actually move on to what these questions actually have in common, does anybody have any idea of what might be, I guess you could say, the common factor between what was seen in question 1 and question 2? Please feel free to put it in the chat because I'm having a look right now. Okay, so the common factor between these two is essentially herpes simplex virus, or HSV. HSV, of course, there's HSV1, HSV2, and HHV1 or HHV2 is, of course, human herpes virus 1 and 2. Now, they can cause slightly different sort of infections. So with HSV1, mainly we can see oral and facial infections, sometimes also affecting the gums. And you often can see sort of whitish vesicles that then evolve to yellowish ulcers that affect essentially the throat, the tongue, the palate, the inner cheeks, and you might get some local lymphadenopathy as well. With HSV2, you can get mainly genital and rectal infection, but again, you also see these vesicles and ulcers, and the swelling can last for some time, and patients can be quite unwell with them in terms of getting fever and tender inguinal lymphadenopathy. With question 1, where we saw that lesion on the lower lip, that was, of course, sometimes we can see cold sores that can be quite common. Whereas for the second question with a young child, that is an example, or the image was portraying essentially eczema hepaticum, which is one of the dermatological emergencies. Now, with HSV, it can often be transmitted by direct and indirect contact with someone who has active HSV. And the reason why eczema hepaticum is essentially an emergency is because these patients can be really unwell with them, and we need to admit them via A&E so that they can actually have IV acyclovir and treatment within an inpatient setting. These two pictures at the bottom, or images, are also of eczema hepaticum. They often kind of look quite monomorphic, which essentially means that the actual vesicles look quite similar to one another. I think it's more easily seen on the right hand side. You can see that they're quite similar to each other, and also they can look like punched out. They often call it punched out erosions, affecting the face and also affecting the torso. But there's quite, of course, it's not one singular lesion. You can see that they are scattered around, and these patients can be quite unwell. And they are also seen with patients who have eczema, and then they get the secondary viral infection of HSV on top, which then, of course, causes these presentations of eczema hepaticum. Okay, so we'll move on to the next one. The next question. This is question 3. So you got a 70-year-old man that attends his GP with a 2-day history of an itchy and painful rash over his abdomen. He has hypertension, diet controlled, and reports that he's usually fit and well except from a recent flu-like illness around 2 weeks ago. He's never had this before, and on examination you can see a stripe of vesicles across his abdomen. How would you manage this? Would it be A, oral acyclovir, B, supportive measures like analgesia, calamine lotion, C, refer to A&E, D, that should be IV acyclovir, apologies, and E, topical acyclovir. So I'll give you a moment to pop your answer in the chat below, and I'll be keeping a lookout. So the oral acyclovir is just repeated, sorry, one of them is oral, one of them is IV, and you've got topical acyclovir as well. Okay, so the answer for this question is D, oral acyclovir. I'll move on to the next question, and then we will again explain what they have in common, or maybe what they don't have in common. So this is question 4 now. So we've got a different patient. It's an 82-year-old lady that's come to her GP with this left orbital swelling and a new painful rash over her left eye and her forehead. Now, she's never had this before in the past, and her past medical history includes hypertension and HIV, for which she's quite well controlled on her antiretrovirals. On examination, she appears fatigued and unwell, and note a blistering rash in the CNV1 distribution and on the tip of her nose. You decide she will need to be admitted to hospital, which your senior agrees. So in this patient, which feature would most strongly support the decision for her to be admitted to hospital? Is it A, background of HIV, B, first episode of shingles, C. Hutchinson sign, D. Painful lesions, or E. Tension headache? I'll give you some time. So this question is slightly trickier than the one before, but hopefully you guys can give it a shot and let me know what you think. Okay, so the answer for this question is C, Hutchinson sign. Has anybody seen Hutchinson sign before, or does anybody know what it is? Just looking in the chat. If not, it's all right. So essentially, Hutchinson sign is when in patients who have shingles that affect the ophthalmic distribution of the trigeminal nerve, so that's CNV1 distribution. Hutchinson sign is a rash that is found on the tip of the nose, the side or the root of the nose. And why that would strongly support the decision for her to be admitted to hospital is that this sign is associated with a high complication rate. Now, other signs that we'd be worried about that would make us consider admitting them to hospital would be, for example, eye pain, photophobia, visual impairment, for example. And you want to admit them to hospital in case of any kind of serious complications, such as meningitis or encephalitis, especially if you're suspecting those serious complications. And you can tell from, of course, the question stem that she's also fatigued and unwell. As opposed to if we go back to this patient here, he's usually fit and well. He had the recent flu-like illness around 2 weeks ago, but aside from that rash, you don't note that he's sort of still got ongoing sort of malaise or fatigue. So this Hutchinson sign is very important. It's something that often will crop up in exams, and it's something that we should be worried about when we see a patient who has shingles. The common thing with question 3 and question 4 is varicella zoster virus. Okay, so VZV is also known as human herpes virus 3. It's highly contagious. It's spread through droplets or direct contact with vesicular fluid. And shingles is reactivation of this latent VZV that remains dormant in the sensory nerve ganglia, such as the dorsal root or the cranial nerve ganglia, after a primary chickenpox infection. So somebody who's had chickenpox in the past then later can develop shingles through this reactivation of the latent VZV. When we have, of course, chickenpox, in shingles, some patients can systemically be okay and not be unwell. But there are times where we need to worry, such as herpes zoster ophthalmicus. So this would be what we saw in question 4, the lady with the shingles affecting the CNV1 ophthalmic division of the trigeminal nerve. And we also would be worried in patients who are severely immunosuppressed patients. So, for example, somebody with a background of HIV, if they're not on any antiretroviral medications and if they have a high viral load, that would make them more susceptible to not only VZV or shingles, but other opportunistic infections. And if you look at the images below, we can see how often we would see these lesions. So it says I've written VZV from chickenpox and shingles to herpes zoster ophthalmicus. While you will commonly see that with chickenpox and shingles, you'll get these vesicles within the dermatomal distribution. You can see that sometimes they kind of look slightly different depending on the skin tone. So on the left, which is an image sourced from black and brown skin, you can see that they are vesicles, but they're not erythematous or reddish compared to what you might see on the right hand side, for example. But those are just things to bear in mind. And of course, the clinical presentation will also be really important and what the patient tells you. But do worry when you have herpes zoster ophthalmicus, and if there's any indication of them being severely immunosuppressed. Okay, so let me know in the questions in the chat below if there's any other questions, and then we'll move on to the next one. Okay, so this is question 6. You have a 26-year-old lady that's admitted with a 3-day history of a cough that's productive of green sputum. She's also got fevers, general malaise, and her bloods show raised inflammatory markers with a white cell count of 19 and a CRP of 250. And her urine pneumococcal antigen testing is positive, which is supportive of an atypical pneumonia. Now, on examination, you note these erythematous target lesions distributed over her palms and her torso, which you report are itchy. There is no involvement of the mucosal membranes. Based on this, what is the most appropriate next step in management? Would it be A, topical acyclovir, B, an antihistamine, C, calamine lotion, D, IV antibiotics for her cap, or E, a referral to dermatology? I'll give you some time to think about it. Let me know in the chat before we move on to the answer. Okay, so the answer for this question would be D, IV antibiotics for the cap. And then I'll move on to the next question soon. The next question that comes will be slightly different, but the reason why we give, or why the answer for this question would be D, IV antibiotics for cap, is it will become apparent slightly later, but it's essentially dependent on what is actually causing this particular rash that we're seeing. So question 7. This is a 38-year-old lady that's come in with a 3-month history of a dry cough, abdominal pain, and mood changes. Her chest x-ray is clear and her bloods are only significant for hypercalcemia. She reports painful, hyperpigmented nodules on her shins, some of which have faded but now resemble bruises. So what is the most likely skin condition? Is it A, erythema multiforme, B, erythema ab igne, C, erythema induratum, D, erythema chronic migrans, or E, erythema nodosum? Let me know in the chat. Okay, so the answer for this question is E, erythema nodosum. So erythema, essentially most of the time we say erythema, we say redness, of course. But of course, there are different kinds of erythema that we will talk about within dermatology. There's erythema multiforme, and this is what we saw in the first question with that lady where we would give IV antibiotics for her cap. For her infection. So erythematous target lesions that are usually on the back of the hands or the feet before spreading to the torso. It can be due to strep pneumo infection and other causes like drugs or viral infections, sarcoidosis and malignancy. The management usually would be to treat the cause, the underlying cause of what's resulted in this particular erythema multiforme coming up, in which in that particular scenario was the infection that she had. The second question following that was that lady, of course, with these lesions or this sort of hyperpigmented nodules on the actual lower limbs that had been quite painful. So they're tender, erythematous. In some skin tones, they look more reddish. In other darker skin tones, they can look more hyperpigmented. Nodular lesions, usually over the shins. And it's essentially linked to inflammation of the subcutaneous fat. There are many causes of erythema nodosum, including pregnancy or sarcoidosis, which that particular scenario hinted at. So we can see that Her bloods, we had the hypercalcemia, and then she had the dry cough. So it's something to think about when we see patients who have erythema nodosum, and these usually can resolve within around 6 weeks. Other erythema XYZ to be aware of. So there are similar um, skin sort of presentations that we see. So on the left hand side, you can see this reticulated erythematous patches with hyperpigmentation and telangiectasia, what we call erythema abigne. It's often due to overexposure of infrared radiation. So in some of the questions, you might see somebody sort of sitting by a fire cooking. That infrared radiation can lead to this sort of erythema abigne to be seen. Compared to on the right hand side, so in the lower right, you can see erythema migrans, and it's a bullseye rash that's at the site of a tick bite, usually when it's seen with Lyme disease, that usually occurs around 1 to 4 weeks after, and it sort of slowly enlarges in size. I guess arguably you can say that it can look quite similar to erythema multiforme, but with erythema migrans, it's usually one bullseye rash that slowly enlarges, whereas erythema multiforme, the specific lesions themselves are slightly smaller, and there's usually many of them, and they're dotted around in terms of the back of the hands and the feet and torso, whereas erythema migrans, that bullseye rash is usually at the site where the tick had bitten the patient. Okay. Alrighty, so we'll move on to the next question. Please do let me know of any questions you might have in the chat below, and I'll keep an eye out. Okay, so this is question 8. You have a 70-year-old man with a background of peripheral vascular disease, atrial fibrillation, and type 2 diabetes that has come to the GP with a skin lesion on his left shin. He states that it's been there for over 6 months, and on inspection, you can see a poorly demarcated erythematous lesion measuring around 2 centimeters by 2 centimeters with an ulcerated base and surrounding dry, shiny skin. What is the next best step in management? Would it be A, oral flucloxacillin, B, no management needed, C, oral prednisolone, D, refer to the vascular team for debridement, or E, compression stockings? Okay, we'll move on to the answer, which in this case is E, compression stockings. So the reason why it's compression stockings is for this particular patient, we were thinking this sort of lesion that we're seeing of whether it might be a venous ulcer. Now, venous ulcers are actually quite common within hospital settings, as in terms of the patients that we see. So a lot of patients do have venous ulcers, and they can sometimes be quite difficult to manage, especially if these ulcers are long-standing. So it's usually due to venous insufficiency, which is improper functioning of the unidirectional valves in the veins, and that results in pooling of the blood around the lower leg. That's why with venous ulcers, they're mainly seen within the gaiter region, which is the mid-calf to the ankle, and these ulcers are characterized by sort of shallow, irregular, sloping edges, and there's often slough and also granulation tissue that is noticeable when you look at it. There are signs of venous insufficiency as seen listed here, and the management of these, aside from keeping it clean, dressed, exercising and elevating the leg, aside from these include compression stockings. Often you can refer for a specialist vascular assessment, and if there's sort of clinical symptoms and signs of infection, we can consider antibiotics plus or minus surgery, which would involve debridement. And on the right hand side, you can see that that's another image of a venous ulcer, which looks slightly similar in appearance to the one that we saw in the question here. So the man that presented to his GP with this lesion, but they can be, of course, more extensive, but commonly you can see between these two that you have that sort of quite ulcerated base with the granulation tissue. Right, we'll move on to the next question. So this is question 10. There's a 65-year-old lady that's come to GP with a 6-month history of a small nodular lesion that's lateral to her right eye. She states that it's been slowly growing larger over time, but doesn't have any pain or itching, any bleeding or discharge. Her past medical history includes hypertension and hypercholesterolemia, and on the mole check you can see that there are solar lentigos over her forearms. What is the most appropriate next step? Is it A, reassure, B, cryotherapy, C, urgent referral to dermatology, D, routine referral to dermatology, or E, a steroid injection? I'll give you a little bit of time to have a think and let me know in the chat. Okay, so the answer for question 10 would be D, routine referral to dermatology. Any ideas what this particular small nodular lesion could be? Okay, so this lesion that we're seeing is a basal cell carcinoma. I put the question stem there and a few sort of keywords in red and also orange that would actually suggest to you why this might be a BCC. So we can see that it's a nodular lesion. So this would be an example of a nodular BCC that's lateral to her right eye. It's slowly growing larger over time. So this slow growth is often seen with BCCs. They often have slow growth and local invasion. And then the relevance of the kind of solar lentigos that you see on mole check would be suggestive of possible increased sun exposure, possibly throughout her lifetime. And of course, when we have BCCs, whilst we have many different types of BCCs, they're often found at sun exposed sites, especially the head and the neck, in this particular patient on her face. Now, how we usually look at a BCC in terms of the features that we see would be initially a pearly flesh-colored papule with telangiectasia, and they can later ulcerate, leaving a central crater. It's not particularly visible, that crater, within the image that we saw for our patient here, but in some of the sort of lesions we do see these. Okay, and of course, if you suspect a BCC, then that would warrant a routine referral to dermatology for removal, such as excision. Great. Any questions so far, guys? Okay, the chat is there if you need it. We'll move on to the next one. Okay, so this is a different case. So this is the BCC case that we saw here, and this would be question 11. So this is a 56-year-old man that's come to dermatology clinic with a lesion over his arm. He first went to his GP regarding other small scaly lesions, which had actually resolved with the cream that the GP had prescribed. And now he complains that this new lesion has rapidly grown and is painful with bleeding and crusting. What is the most appropriate next step in management? Is it A, reassure, B, curettage and cautery, C, punch biopsy, D, excision, or E, watch and wait? Okay, the answer to question 11 is D, excision. That's because what we're seeing here is a SCC, so a squamous cell carcinoma. Now, this is of course a type of skin cancer, and it's usually seen on more sun-exposed sites like the head, the neck, the dorsum of the hands and the arms. How they're slightly different to BCCs is, of course, these are rapidly expanding. They're often ulcerated nodules, plus or minus areas of bleeding. Some risk factors for SCC include actinic keratoses, smoking, immunosuppression. So in lots of questions, they might hint at sort of a patient being a renal transplant patient, and what they are at increased, sort of what increased risk of cancer they might be at, which would be in this particular case an SCC, and also if patients have a background of HIV that's not well controlled on antiretrovirals. And the management for an SCC would be surgical excision. Now, if the lesion themselves are in cosmetically important areas, then we would be considering Mohs micrographic surgery. I've just included a small section below on Bowen's disease. So Bowen's disease is also known as intraepithelial SCC, also known as precancerous SCC or SCC in situ. Now, it's precancerous SCC, sorry. So there's a potential that, of course, these will develop into SCC. But the lesions themselves, I just wanted to show you guys how it can be slightly different to what we would expect from an SCC. So these lesions for Bowen's disease are irregular, orange, reddish, brown, scaly plaques, and they can be up to several centimeters in diameter. And they're often asymmetrically distributed on sun-exposed sites. In terms of management, you can excise or you can use topical treatments such as 5-FU cream or 5-fluorouracil. And the overarching importance with not only BCCs and SCCs, but skin cancers in general, of course, would be counselling on sun safety, so SPF 50, and just making sure that they are aware of measures to take in terms of protecting themselves and their skin from the sun. Okay. So if there's any questions, please let me know. But the questions ranging from that patient we had with the venous ulcers all the way through to the patients that we saw with BCC and SCC would be that, of course, sometimes our patients can come in with what we think is an ulcer, but the clinical context is really, really key. So think about your surgical sieve. Think about the different causes and potential underlying etiologies for ulcers that we can see that come through the door. So we can think about vascular. We're thinking about arterial and venous ulcers. So if you look at the table on the right hand side from New England Journal of Medicine, so you can see that there are some images of venous ulcers in the second column, and an image of the arterial ulcer in the third column. Now they look slightly different from each other. We talked about the venous ulcers previously in that question. With the arterial ulcers, they're of course more punched out, they're deep and irregular, and they often can have this necrotic tissue. Whereas with the venous ulcers, it was more the granulation tissue that we saw and the slough at the base. Now, we want to be thinking, of course, also about other types of ulcers that might look similar to, let's say, a venous ulcer. So if you look at the image on the left-hand side by NHS, that's pyoderma gangrenosum. And that can often sometimes be seen with patients who have inflammatory bowel disease. So that's more of an autoimmune / inflammatory sort of underlying presentation for these sorts of ulcers. And it's really important to be able to look at the question that they presented to you and have a think about whether they have any particular risk factors, for example, for a venous ulcer that we mentioned earlier. So, for example, venous insufficiency, if they've got those signs that we mentioned in the gator region, like lipodermatosclerosis or hemosiderin deposition, or if their clinical history, for example, suggests sort of GI symptoms that they've been having, or extraintestinal manifestations that we might see with Crohn's disease, whether the ulcers are pointing more towards an autoimmune or an inflammatory process. Because the lesions, of course, they can sometimes look quite similar, but the management, of course, would be overall very different. So with pyoderma gangrenosum, we wouldn't be thinking compression stockings. We'd be thinking more about whether they might need steroids, whether they will need, of course, to be seen by the IBD team, for example, as opposed to the vascular team. And of course, with ulcers, thinking neoplastic, so SCC, BCC that we talked about, that can often, well, SCC in particular, that can present with lesions that can be ulcerated. But BCCs can sometimes have that central crater, which slightly can look ulcerated in certain patients. Great. So those are quite a few different ulcers to think about. And these sort of presentations are often very commonly tested within the UKMLA and within medical school exams. And just to be aware of course, with neuropathic ulcers, pressure ulcers or pressure sores, that's also quite commonly seen within questions. It's in the table here, but it's also in our previous session, session 1 of the Dermatology Mind the Bleep UKMLA final series. If you guys want to have a look at that session on YouTube, that has also high yield MCQs on a lot of the commonly tested conditions and presentations for derm within the UKMLA exam. Okay. Great. So that draws the session to a close. I'm aware I've been talking for quite a while. There are quite a few questions and different topics that were covered here. So please, I'll be keeping an eye out on the chat now. Please let me know if you have any questions, and I'll hang around to see if anything pops up, and if there's anything I can help with. I'll give about 5 minutes if there's anything you guys want to have a think about, but I'll be here if there are any questions, of course. If you're still having a think or you're not, please do fill out the feedback form as part of our Mind the Bleep UKMLA series. And please, of course, do keep an eye out for our upcoming session. So this is our DEM session 2. That's in February. There'll be more sessions coming up in March as well, by myself and Priya. So yes, so please keep an eye out for those. And to everybody that's, of course, tuned in today, thank you very, very much. I hope it's been useful, and I hope that it's helped somewhat with kind of picking apart dermatology, similar dermatological presentations and conditions, because there are quite a lot of them and they can be quite tricky. But I hope that these have helped, these questions and pictures. So that's the end of the session. Thank you all very, very much. I'll stop sharing my screen now. Okay, and see you all at the next session. Look forward to seeing you guys soon. Good luck and take care. Bye.